Welcome from ASH 2018 here in San Diego. What's new on relapsed follicular lymphoma? Well, there are a couple of important things also clinical-wise. First of all, what about the standard of care so far, which is still antibody-chemo combination? We have seen new data on a randomized trial randomizing bendamustine plus minus ofatumumab. To make a long story short, large international study, no difference in clinical outcome. What does that mean? Well, in contrast to obinutuzumab, obviously ofatumumab is not superior to rituximab. However, the field is quickly moving to targeted therapy. And what are the options? Well, last year we've heard about the relevance trial, which is academic-wise a historical trial because this is the first time that targeted therapy is as good as chemotherapy. At this meeting now we have an update on a study Augment in relapsed follicular lymphoma, and that was a randomized trial between rituximab plus minus lenalidomide. And not surprisingly, there was a benefit in PFS, but also overall survival. And I do believe this will finally guide to registration of lenalidomide in relapsed follicular lymphoma. What is the current status so far? My personal belief is that PI3K inhibition is really the most powerful targeted therapy in follicular lymphoma. What we have experienced so far with the current PI3K inhibitors, the first one was Idela, that we have observed quite some time of toxicity. And that's important note as this toxicity occurs later on, after a couple of weeks. So one really has to really carefully observe these patients. On the other hand, there are new compounds on the market. One is duvelisib, and it's somewhat comparable to Idela, and both of these compounds have a black box warning. So you have to be aware of the side effects. In contrast, copandisib, which is an alpha-delta inhibitor, is much easier to perform in clinical practice. At this meeting now, we presented the data on the POT24 patients. So the patients who relapse within 2 years after first-line chemotherapy. These are about the majority of the cases being included in the initial pivotal trial. And what we have observed, all of these patients were being treated with the current standard of care, essentially 80% with combined immunochemotherapy, 20% with chemotherapy only for different reasons. And for the patients who relapsed early, what we've seen is, first message, the majority of them had high expression of the PI3K pathway. The second point is that even in this high-risk patient population, we've seen high response rates in the range of 60+% in the follicular ones, and that is really reiterating, and that is my personal belief, if you have early relapses after chemo, chemo won't make the job in salvage treatment, but we have to move on to these targeted therapies. So where will we be, let's say, after this ASH in our daily routine? I think first line still antibody plus chemotherapy remains the standard of care, either obinutuzumab or rituximab. In relapse, now we really have data supporting the application of these targeted therapies, and then it's probably dependent on the different side effect profile, whether to move on either to the R-square one or to move on to the PI3K inhibition. And in my experience, I definitely have to say, based on toxicity and side effects, my favorite drug is copandisib.